Hello, and welcome to today's webinar, Creating a Shared Community Care Plan. My name is Laurel Rodriguez, and I am the Director of Marketing at Ecovia Solutions. Our presenter today is Jim Calanni, Principal Program Manager for Ecovia Solutions. Before joining Ecovia Solutions, Jim was the Chief Technology Officer for Community Health Partnership, a member-based coalition that managed care for over 180,000 members in Region 7 of Colorado's Accountable Health Collaborative. At Community Health Partnership, Jim led an initiative to develop a community-based strategy that optimized care delivery for high-risk populations, including homeless, long-term services and supports, elderly, blind, and disabled, and those who overutilize the emergency departments. Jim has 25 years of experience in health information technology leadership as a Juris Doctorate in Law, a Master's in Business Administration, and a Bachelor's of Science in Biochemistry. Today, Jim is going to discuss the role a shared community care plan plays in developing healthier individuals, families, and communities, his experience designing and developing a data infrastructure that linked primary care, mental health, and social services providers across southern Colorado, and 6 things to consider when creating a care coordination framework. Just a quick housekeeping note before we turn the webinar over to Jim. Your phone lines will be muted throughout the entire presentation. We invite you to submit questions at any time using the question area on the webinar panel. Jim will address the questions after his presentation. You can also follow the webinar conversation on Twitter or submit questions using the SCCP hashtag you see on the screen. Jim, I will go ahead and turn the time over to you.
Oh, great. Thanks, Laurel, and welcome, everyone. I'm excited to be here to talk about building a technology stack to actuate, a true community care program, and give a little bit of a case history on my previous experience before coming to Ecovia. I will say that I actually was a client of Ecovia before coming to Ecovia, and believe in the application and the company, and that's one of the reasons I moved over here. It helped me realize some of the technology goals I was trying to meet. So the purpose here is to talk about a true community care program as opposed to typical historical EHR-type solutions or solutions that revolve around historical charting of things that have happened retroactively or in the past, and how to try and get in front of some of those conditions using technology. So start off real quick here and talk about just the basic 30,000-foot overview. The health and human services piece of healthcare or the health journey has been one of the hardest things to conquer. Clinical electronic data is somewhat shareable and usable by most of the providers in the community, but the social determinant pieces of it have been lacking and seem to be responsible for the majority of the healthcare spend. I've got a slide here I'm presenting right now that just talks about, it really shows what the triple aim was trying to do, and unfortunately, cost is a factor here. Payment mechanisms are a factor on how care is provided, and the folks that are managing the gaps in care, the social determinants of care, health and human services, are not well-funded organizations, and it's really one of the places that can have the most impact on dealing with, providing better care for folks at a lower cost. Specifically, redundancy in care that's provided, duplicative labs, duplicative radiation, et cetera, and just not understanding the entire place that a patient or a client might be in. So here's a good screen. This kind of talks about where we need to move. The paradigm shift that I saw when I took my previous position at Community Health Partnerships here in Colorado was moving from disease treatment, which is frankly what healthcare has kind of been, is more retroactive disease treatment, to a prevention mode, and how do we get in front of the problem of dealing with chronic conditions or social economic factors that contribute to lower health care and lower health, reduced health for folks. So that's where we're at. I like this slide right here. I've always liked this slide because it does show a good graphic representation of on the left side of, what equality may look like and what health equity really represents, which is there are folks that may or may not need the type of extreme health care or costs that are required by some folks that may just not be able to get across the line with other factors that are outside of just the clinical factors but have to do with the social determinants of health. I will say that in implementing a health information exchange program that we did out here in Colorado, it was really focused around the aggregation of clinical physician EHR type data from acute settings in hospitals. The program initially out here in Colorado was also focused on connecting ambulatory providers into a true health information exchange system, and then merging that information with historical claims data for patients and trying to create a virtual electronic picture of the medical history and then begin to apply some data analytics around how to get in front of the program. So, and again, all aimed at the triple aim here of reducing care while increasing health quality. Bidirectional exchange of health data, as everyone on this call knows, is very difficult, which is interesting, and I'll get into that later as to why this is one of the only verticals that has had such a hard time with adoption of how to move this needle forward. And I won't be getting too deep into prescriptive type data analytics and data science on this, but there will be a follow-up webinar where we can dig deeper into that. But the integration of behavioral health and physical health is very topical right now. And I would add that the social determinants of health are now the hot topic, and I'm very excited about being a part of trying to merge those things through technology. So I'll go on here and discuss a little bit. I think this won't be a surprise to most people, but this is just a basic factual curve of the spend in the United States, and you can see that there's a logarithmic curve here. If you look at the knee of the red line, the knee of the curve, an exponential expanse of expense. This is just a cost curve for at about age 60, right about the time folks get into the Medicare space. Just a fact, 5% of the Medicaid population in general accounts for about 55% of the Medicaid spend. And about 20% of the Medicare population accounts for about 70% of the spend. So in Colorado, I can tell you we did some data analytics after we designed the platform I'll show you in a moment. And we looked at where the biggest spend was, where are the dollars being spent. And ironically, the top 4 providers were not hospitals or clinical settings. They were Walgreens, 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 and CVS. So ironically, the majority of the spend was being spent on pharmaceuticals, and there was not a lot of spend being spent on prevention or prevention methodologies. The top conditions that we looked at were severe mental illness, long-term support and services, skilled nursing facilities, how we could impact those areas, elderly, blind, disabled, and chronic comorbidities are the things that we focused on. So we wanted to build an infrastructure that was capable of collecting data at the ground level and then moving that data into an organized fashion, coalescing it into more of information, and then moving that information into knowledge by beginning to apply some data analytics and science to it. And then the final icing on the cake is what I'll call it, is then how do we get this information into the hands of the people that can actually impact it and do something, which is a term I like to use as the health community or a health team. So that's what we did. But this curve is frankly alarming when you look at it for a country that has all of the applications and intelligence that we have. We should be able to stop this logarithmic progression of the cost, and we just have not been able to do it so far in the health industry. So whole person care. On a whole person care paradigm, this won't be new to most of you, but so we have a primary care setting or an acute setting where we're dealing with clinical applications on how to deal with things that have already happened. These are diseases, people come in because they're sick. Unless of course, there is a commercial payer, they're very good at actually reaching out and doing some predictive type analytics. And for example, a 50-year-old man is going to get an email from Anthem that they have a colonoscopy due. So that's good. But integrating that with behavioral health and mental health situations, as well as incorporating the final piece of this triangle here, which is the community-based organizations. So things from TANF and SNAP and your DHS departments, as well as faith-based organizations, soup kitchens, et cetera. So this is pretty much the holy grail here. If there's a way to use technology to integrate these three tiers, that would be the holy grail. Again, most recently there was a news release from Judy Faulkner at Epic, a great company, purporting out a comprehensive health record, which is expanding their EHR. And I put a quote up here that is directly out of their press release. But it talks about having more of a comprehensive health record. The health record that they're discussing here is a clinical health record. So just to be fair, it is a historical disease health record of what's happened to somebody in the past. There aren't analytics or anything applied to this health record. It's just really a report card, so to speak, of what's happened to this person. Actually, in the same week, Apple came out with an application for the iPhone, which is very interesting, and it's good. I believe I have a graphic after this I'll share with you. But it puts the patient's health record very similar to a primary care provider's portal. So if you have a primary care provider and you go in and you can pull up your application, you can do it from your iPhone. Again, it's a move in the right direction. One of the concerns, not really concerns, but with any technology movement like Epic and Apple are talking about, is that what you're getting is really only as good as the information that's behind it. So the health record you're seeing is a health record that is resident in the data that is being pushed out into that front-end application. Right? So if a provider or a patient is to see, here's your health record, it's really the health record that only came from the data sources that they have access to. So again, it's I think the real answer, the true place we want to get to is a true community shared care plan where it's not just clinical information, it's also information, I frankly believe the most important information, that comes from the field. So it's information from care coordinators, care navigators, DHS folks, social services providers that is then integrated into that clinical information to provide a true picture of what's happening with that person. We've got a good graphic here that I'll share with you. So if you look at this kind of continuum of facilities and health neighborhood, if you will, you've got, in a perfect world, sharing of information between the acute care facilities, primary care providers. You have LTSS facilities, behavioral health, your community mental health centers, youth and family type services. You have HUD information, and I deal specifically right now with a homeless population that we're trying to figure out how to actuate information and get them back into society and be able to track where they're going and the impacted events that can happen in their life that can become a chronic type condition. IDD population, and then eventually, hopefully, getting them into housing and then workforce services, getting them back into contributing to society and so forth. So this is a great graphic. It shows pretty much a community. So here's a community that's showing a lot of the things we just saw on the last slide that shows everything from dealing with our youth to housing to workforce services to acute care facilities, urgent care facilities, PCMPs, outpatient treatments, with the patient in the center of it, and really having a true comprehensive connection of these people. Now you can imagine each one of these facilities that's located here has different IT infrastructure, different vendors, different types of EHR systems or tracking systems. Most of the most important pieces, like DHS, Department of Health and Human Services, SNAP, TANF, those folks usually have the least funding of anybody. So a lot of the ones, at least in my experience here in Colorado Springs in the Pikes Peak area, are still operating on spreadsheets. And that's an area that can be impacted, I believe, the most with technology. So real quick, this won't be a new slide for most people, but it's Maslow's hierarchy of social needs. So when looking at how do we fill in the gaps of this healthcare journey for a person, we look at the bottom, basic needs. We have physiological needs, shelter, food, security, etc. It then moves into a kind of a more mental health type needs. Once you have safety and things like that, then do you have friendship? Do you have family? Do you have a care team around you to help you build up your self-esteem? And as we move to the top of the hierarchy here, self-actuation, which is having a job, being able to provide and be a contributing member to society. So I'll get quickly past this, but the next slide I think shows really well. If you look at this hierarchy of needs, it really translates well right into this community picture we're looking at. In other words, the psychological needs of food and water, et cetera, you can find a facility in here that handles that in any community, just about any community. I want to make an exception, not talking about rural. That is a different conversation, and I don't want to go down that rabbit hole today. But in a general non-rural type community, you have these facilities available to a patient. So safety is there. Out here in Colorado Springs, we work very closely with our fire department, which is our 911 CARES unit that answered any 911 emergency calls, and we had an ED diversion program that worked very well. So having the police and fire involved in this are part of the health neighborhood if we truly want to bridge these gaps in care. So I'll move on to the next slide here and talk a little bit more about the case study when I was at Community Health Partnership most recently. It's a wonderful position. When I took this position at Community Health Partnership, the idea was to extend the HIE, or the Health Information Exchange, functionality in our state. We are fortunate enough here in Colorado to have two very functioning health information exchanges. One is CORIO, which is a Colorado Organization for Health Information Exchange, and then the other one is QHN, which is Quality Health Networks on the Western Slope. And they do work very well together. However, most of the information these two organizations were able to coalesce were acute data. It's because it was probably less of a lift. Most of the hospitals and facilities were either on Epic or Meditech, possibly Cerner. So once you've added a hospital, it's pretty simple to add another hospital in. In our community down here, we had, of the 42 primary care providers, 38 different EHR systems. So to bring in ambulatory, non-acute data into a data environment, or a data warehouse type that our HIE had, is a very massive technology list. We're dealing with EHR vendors at one facility, GE Centricity or eClinicalWorks or NextGen, et cetera. So it's a much larger lift to bring those together. So that was the first piece of the program, was to at least start aggregating this clinical data, not just from acute settings, but also real-time data in the form of a continuity of care document, or a CCD, from a primary care provider into the state HIA. We had a very good partnership with CORIO, and we're able to actually do that. And so we're able to, most of the providers in Colorado Springs and Pikes Peak area are now contributing some level of clinical data into the HIE here. So that makes the rest of what we're going to talk about a little bit easier. So as I mentioned, apparently I didn't use spell check. It's not provider HERS, it's provider EHRs. But connecting ambulatory providers as well into the state HIE, consolidating real-time data, and then actuating admit, discharge, and transfer data from acute care settings, but placing that data eventually into the hands of the people that can do something about it. It's one thing to know that one of your patients is in the ER, but what are you going to do about it? So that was the initial concept of this. And then eventually putting out a GUI, or a graphic user interface, on the front end of this. Once we've aggregated this data, we've turned it into information through some type of data integration engine, put it into a safe environment, a government secure, safe, HIPAA-compliant environment, and then pushing that information out into the hands of the people who can use it. And as I mentioned, the next time we'll talk more in detail about then using actual data science with that knowledge to do something about it and be able to impact people. So this is a great screen here to talk about. So we start out at the very bottom of this stack, I'm sure this is not a new graphic for many people here too. But just gathering data is one thing. So how do you get data? Who are you getting it from? Is the data necessary? Is it good data? Is it bad data? How do you sanitize it? Moving that data then and organizing it, structuring it in a way that it makes sense. In our situation, it was not just clinical data. Then we're merging clinical and claims data, historical claims data together, and building this infrastructure package, so to speak, of what the patient's history and current state looks like, and then moving that into some type of contextual knowledge. Okay, so now we know what the picture looks like real time, and we know what it's looked like in the past, and then what do we do with it, right? How do we move it to a decision type model where we can not only do data science on historical things and trends in population health, but also move that into where we can put it in the hands of people and say, if this happens, then what, right? So if then what? If this happens to this person, then they've been in the ER at X amount of times, which is over our acceptable level, and we need to impact and reach out to that person. I will add one other note. With the front-end GUI care coordination type tool like Ecovia has, with ClientTrack, you're actually able then to also take in care coordination or real in-field notes from the people talking to the clients. You may find out that it may not be worth the time to reach out to a certain person if, even though they need the help, they're not going to take it. And so that kind of information only comes from the input from the people that are actually touching the client. So this is the solution design architecture that we developed over the last few years. We'll start from the right-hand side of your screen. So this is the data input. So the bottom of the pyramid I just showed, this is the data input. This is the information that's coming in. So for example, in this case, you have BIDM, which is our system for the state of Colorado for healthcare policy and finance. If you're a Medicaid provider in the state, you will receive claims data. You'll receive claims data on the roster of patients that are in your care. And that usually comes a little bit latent, maybe 2 months out after the fact. But that claims data is very valuable, so that has to get put somewhere. And you'll see an arrow going into an integration engine that I'll get into in a moment. In the state of Colorado, until recently, the behavioral health piece was separated out. So there was a separate data set coming in for behavioral health instances. In the state of Colorado, behavioral health is a capitated payment, so it was just a different entity than the collaborative care organization. So another data set, throw it in the box, right, into the integration engine. Then on the final piece, you have the Coreo data, which is the state HIE that we worked with. And so you had originally just acute data coming in from the hospitals. In our program, then we began to bring in primary care provider, ambulatory type data. So now we have clinical data, we have behavioral health data, we have claims data. All of it goes through this integration engine. We selected a vendor. All your data is the name of the vendor, but they had a BizExplorer tool, which actually made a lot of this possible. In other words, it would take it in, didn't really care about who the source was or what it looked like. It was very vendor agnostic, right? So it's a variable-driven engine that would just take whatever it was and then figure it out and then put it into a true data warehouse, if you will, to have kind of a more consolidated patient record. I won't get into too many of the details on the diagram, but you can imagine at this time now you have your internal data analysts that are able to start doing some real data reporting and looking at historical trends, looking at prescriptive type analytics that could be done as you build this picture of this patient. And then the final piece, as I mentioned, was to put the icing on the cake, so to speak, which was to add a GUI or a real graphic user interface that could be put out into the community with role-based access. For instance, if it's going to a care provider, a care coordinator for that patient, they may see everything that they need to see, every view that they want. But that view needed to be very tailored, right, and flexible around what they wanted to see in their workflow. If it was a delegated care, we use a delegated care model as well. So there may be physician practices that had delegated care coordinators. Maybe their view is a little bit different. It's tailored down to the member roster that they need to see, the patients that they can touch. So that's a different piece of it. And then community agencies. We worked very closely with our DHS here, and so they may just want to see this piece. And even if you're going to send it to a soup kitchen or the Marian House, which is one of the Catholic Health Initiative funded soup kitchens here. Maybe it's a very different view there. It's just patient name, care coordinator, here's the care coordinator's contact information. So that when they come, maybe when they show up and present at the soup kitchen, then if that information is put in, it goes back to the care coordinator that's responsible, and they have the ability to reach out to that patient and say, why are you there? Like, what happened? Like, you had a job, and now you're at a soup kitchen. So that's the infrastructure, data collection, put it into an information format, and turn it into knowledge. If you look at the very bottom of the left-hand screen here, data analytics, prescriptive stuff, that's what we're going to talk about on the next webinar, but that's where the magic really happens, where you're able to take all this data and information and knowledge and actuate it into real events that are impactable. So to summarize on this part of it, simplification of data collection, streamlining data, and pushing it out into a true user interface. But we're beginning now to build a true community shared care plan. It's not just a historical document of what's happened to the patient from a clinical standpoint or a claim standpoint, but incorporating the real-time information about the social status of this person. Are they working? Do they have transportation? If they had transportation, would they use it? And where do you place your efforts and find the people you can impact the best? So I'm going to talk, these are kind of the lessons we learned here, and I'll go through this quickly because I want to get through some of my suggestions on somebody that's looking at really developing a true community shared care plan. So I've mentioned both of these, but it's the incorporation of the things that people maybe don't think about all the time in the healthcare industry, and that is family communication, faith-based organizations that keep people from going down the wrong track, health and human services connectivity, informatics, wearables, telehealth. How do those things incorporate and fill in those gaps on this continuum of this person's care? Right, so that's kind of what we learned on our process. Thought it was very successful. I want to spend a little bit of time on my recommendations and my experience through this. I've been working with the great people I've worked at on maybe 6 steps we should look at if you're looking at really doing a true community care coordination framework. The first one, as it always is what's the why? Right? So why are you trying to do this? Do you want to why do you want to do this? Are you an ACO that's trying to manage costs mainly first and hopefully improve health? Are you a commercial payer that wants to do this? Are you a community organization that wants a non-for-profit that's trying to impact the health of your population health? But what's the reason you're trying to? I think that's the most important thing to start with. The second one is who, which is in who controls the data you're trying to get. It can be a very disruptive and complicated process, as you all know, to go knocking on doors to get access to data for people. There are certain environments that's a little easier. If you are a county-type organization dealing with just county facilities, or if you are a true ACO, then you can get provider compliance and social services type compliance a little bit easier, but it can be complex. So who's got the information? Who controls it? Who owns the domain of the information that you need to get? Right? Some of the typical barriers on this obviously are EHR vendors. There's nothing against them. They just it costs money to open up the key to be able to take that data and put it into a different format and be able to share it. I'll go back to the slide I showed you with the architecture. So the data integration engine is key, right? It's how you are able to bypass some of these bifurcated data systems and technologies that they're being sent to you with. And then also another barrier is who are the payers, right? So a commercial payer is one thing. They're very good at doing their utilization management, and they have very good tools, analytic tools. But is it a Medicaid payer? Is it Medicare? Is it TRICARE? Is it a government-type payer? Or is it a self-funded organization? Here in Colorado Springs, we have Colorado Springs Utilities, so it's a self-funded payer. So very different sources, I think, all have the same aligned outcomes that they're looking for. So then how are you going to do it, right? So how are you going to impact what you're trying to do? Do you have a leader in the community? Who's going to drive this for you? Again, if it's an ACO, then that's a little bit easier. Maybe it's a not-for-profit community organization that does it, but who's going to convene the network, the real network of social services, housing, education, employment, jails, reentry type programs, food banks, clinical and behavioral health. I kind of skipped over what, and that's very important. So what do you plan to do with it? What are you going to do with the information? Once you've got this great body of information, how are you going to dispense it out throughout the community? Are you going to put it out into the hands of everybody? And if you are, there are very serious considerations that have to be taken into account. For example, security and type role-based access, et cetera. And I'll get to that in a minute. Again, when are you planning to? Like, when do you want to do this? Do you want to do it in the next month? Do you want to do it in the next year? Just know that you're going to have to overcome the legal considerations of how you gather such data, the very serious privacy considerations on how you distribute such data. So data governance is very important when you're looking at where you're going to distribute it, who gets to see what. So discussions about harmonization of data and role-based access are very important at the beginning of this, especially if you're going to be sharing a true community plan, care plan on a person throughout the community. And then, finally, during this development process, when you're building out what your care plan model is going to look like to serve your why and your what, consider aligning the goals around population health, special groups, organizations that you'd like to target for interventions, and staying open to new ideas and technologies. Once you have your basic framework down, and keep an open-ended architecture. Again, back to not only the integration piece of this and how you integrate this data into a warehouse, but probably even more important is where you're placing that data. I personally have worked very closely and do still with Microsoft's Azure platform. It's a government platform. It is, I believe, the highest rated platform to be able to place data in a secure environment. And Microsoft is leading the industry with machine learning, et cetera, and that's all encompassed in that environment. So if you have a safe place for the data to land, you have a way to take all these disparate sources of data through an integration engine and place it there, then what are you going to do with it? How are you going to get it out there? And that, again, is the icing on the cake. That is the Ecovia tool. Like I said, I used to be a client of theirs, and I believed in it enough that I came to work here. But it is the flexibility. How can you flex and change role-based access? How can you put different rules in it and be able to publish this out to the true health community, not just healthcare providers, but service providers, health and human services, et cetera. One other point I wanted to bring up, which is something especially now that folks need to think about if you're designing how you want your framework to look like, if you want to go this route, and that is keeping in mind when you're designing your technology infrastructure, it's important if you're going to have a true data mart, so to speak, what are you going to do to ingest IoT, Internet of Things, or I call it Internet of Everything, but Internet of Things data feeds. For example, wearables, right? Prescription bottles that may actually be able to feed into a Wi-Fi feed and let a care coordinator know whether someone is taking their medication. And those things are real, and they're happening right now. How are you going to take that, ingest that information, and then publish that out to the front-end GUI, so where it's actionable? Very important in the design phase of this. And then I will move on and with one other note on the design, and that is, what are you going to do data analytics-wise? Are you going to do prescriptive type analytics where you're going to get in front of things? You're going to look at a population, do some trending with your data scientists and analysts and say, if this happens, then this, and then inform alerting or event notification services, or ENS is what I call it. But to be able to then put an alert in the flow, in the workflow, totem pole that day of a care coordinator that says, red dot, you need to call this person because this happened. And so that data science is probably the most important key, but you can't do any of this without this technology stack and building up the stack. But once you can do that, then you can actually start incorporating the information that these care coordinators are collecting or other service providers are collecting, and then build that into your artificial intelligence or machine learning, so to speak, and then republish that out. So it's a continual fluid, if this then that process that needs to be incorporated, and that's a whole different topic, but we can get into the data analytics next time. So I know we have probably about 20 minutes left. I will open this up. If anyone has any questions, I would love to take them.
All right. Well, thanks so much, Jim, and thanks to everyone that has joined us. So please go ahead and submit any questions through the question area on the webinar panel. So one question we have is, what if we don't have a health information exchange at our disposal? How do we do the care plan or the community care coordination plan?
That's a good question. So it's a little more difficult. I mean, like I said, there are not too many true HIEs, and we're very fortunate here to have 2 in Colorado, so that made life a lot easier. But if you don't have a true HIE, there's a couple routes that you can go. One is that data can be accessed directly from the facilities that are providing it, and my suggestion would be to start with the acute care facilities, again, because it's a lower lift. You're dealing with 1 to 3 possible EHR vendors that you just need to incorporate that data. And then moving out from there, I think placing the GUI tool or the front-end application tool, care coordination tool, in the hands of the people that are actually meeting with the patients and having an impactable experience with them is the most important. So you can gather data there. The clinical data is extremely important, but I don't know that I would say it's more important than the social determinant data, which you don't need a health information exchange to gather the social determinant data. What you need is people in the field to have the ability to have either a portal access or some inexpensive ability to put information into a data warehouse like we do with Microsoft right now. And so the clinical information, again, is important. It's very difficult and expensive to be able to coalesce that unless you have the right integration type tool. But there are, BAAs and legal considerations on what information are people going to provide, et cetera. So if you don't have one, I would suggest starting at the ground level. I can't really speak right now about the program that I'm working on, but I will mention that it is taking that approach. That approach is before we handle the massive lift of moving clinical information into an environment and terminology services and normalization of, is A1C with a capital A going to work if A1C from another organization has a lowercase a? Or is John Smith or Jay Smith the same person? It can be complicated with the clinical piece, but care coordination type notes that can come in on a front-end application can be very useful, and it's a lower lift, it's less expensive, and that would be my suggestion to start.
Okay, perfect. Thank you. So the next question we have is around HIPAA. How are HIPAA considerations best dealt with when deploying a shared solution?
When dealing with this information sharing, there are a few things. So there's just the general HIPAA information. What can we share with somebody? Do we have the vehicles in place, BAAs, an OCR with somebody that we're able to at least provide them? They must have some relationship with the patient or the client. So are those things in place? But again, I think it has to do with, if you think of a continuum, the continuum of data that we're talking about, now go back to data, not just information, but data. If you think about the continuum of, where does it sit, who's it going to, what happens when it gets there, and what's the result, how does it get dispensed of, disposed of, or disseminated? There are HIPAA considerations just if you have a physician's office on how you manage that information. When you transmit that, what's the method of transmission? How's that information being sent, and where is it being sent to, and what are their protocols and their data governance structure once it lands there, right? And then what are they going to do with it? And then when they don't have a relationship anymore with the person or the patient, then how is it destroyed or removed? So those are all considerations. My suggestion would be I hate to be blunt, but pass the risk on to the extent that you can through insurance or legal documents. I would pass the risk on to the next party such that their data governance protocols are at least, if not more, restrictive than yours. And I mean, we could go on forever about flash drives. You know, you have a BAA with an organization, they send it some information to you because, say, you're a specialist or a physical therapist or a care coordinator, and then somebody takes information home on a flash drive, right? So as long as you ensure that you have the protocols that have made them at least meet or exceed yours, I think is the most important thing. Having the secure environment, though, so if you're going to be the data mart, if you're going to own that data mart like I showed you in that exhibit I did, then that's where, you know, a Microsoft-type solution, it makes the most sense. The risk has been shared. They welcome that risk, and that's what you pay for, right? But you know that the data is there. It's in a very safe environment. And so really then, if you know that, then you can focus your attention on what is the risk when you transmit that data out, right? What's the risk in transmitting it? What's the risk when it lands where it needs to land? And what's the risk in what that person where it lands at does with it? So data governance, I guess, would be the answer to that question.
Okay, and thank you. That one leads into our next question. How do you check the security of your data?
Okay, so good question. Security, I don't know exactly. Maybe whoever sent that could expound on that a little bit more, but I can take a guess. So security meaning how secure is it? I mean, so there are a few things. Again, if you're dealing with the data that is housed, that's not in transit, right, that is in an idle state, that you get to decide where it goes. If that data is secure, again, it really depends on the protocols and the organization or resource that you have that secures that data. So, and those are, you know, typical SLA type arrangements and legal ramifications around how they manage that. Most of the organizations that are leading that do a pretty good job at that. Security of your data in transit, that's a, you know, a pipe question. How are you transmitting the data, et cetera? What are the risks in transmitting in that route? I can tell you people have a lot of concern, which is valid, about transmission of data, and as to, you know, this is complicated, or HIPAA or SUDS data, you know, 42 CFR type stuff. Or they can fax it, which I would say, I don't know which one is more dangerous if you hit the wrong number when you fax something. So again, it comes down to data governance. If you want to test the security of your data, I definitely would recommend frequent security audits, not only on processes, policies, procedures, but also break audits where they try and break the system. Testing your security of your data once it's outside of your domain really, again, comes down to more paper. It comes down to you can only bear the risk to a certain degree, so you have a responsibility, a fiduciary duty to that patient to make sure that the people you're sending it to have protocols and procedures in place that are, again, are at least as stringent as yours are, that meet the HIPAA requirement.
Perfect, thank you. So the next question is also about data sharing. So the question is, how can you get doctors to want to share data with social service providers and vice versa? In my experience, they are hesitant.
Oh, that has been my experience too. I mean, and specifically, I can tell you from personal experience on a mental health, behavioral health standpoint. You can imagine. So in our, and this isn't answering the question, but I'll get there. In my experience, so you have a mental health provider that's willing to share data, right? They know this is the way to go. We've got to begin sharing data with the primary care physicians or other people in the community that are touching this patient. But when you're transmitting, say, for example, a continuity of care document, so you have a clinical document in a certain architecture, until you get down to the data element where you can redact a few things, so you have a patient, it's a medical patient or a behavioral health patient that has this drug prescribed to them. And it's a drug that makes a direct reference to a certain condition, right? So Thorazine. What I've experienced is they are very hesitant and won't do it. They'd rather not send the document, without the ability to just redact that piece of it. So that's very technical stuff. It's cutting edge. It's coming soon. But the ability to send that CCD and that architecture with just that information redacted out. But in the meantime, they have to look at their own risk. And so we were talking about security of your data. They're saying we'd rather just not send that document at all. So it is difficult. I think to answer the question that was asked, how does that get encouraged? I believe that the law of physics on equilibrium is only out-trumped by the law of economics, which is eventually this pay-for-performance, pay-for-value that we've heard about in these different varied reimbursement models eventually will be trumped by economics. And it will become a true ACO, especially considering the new administration and things that are happening with potential block funding, that we'll find out that you're going to have physicians and organizations and care providers and organizations that could lose their retirements if they don't make sure that the continuum of care happens outside of the doctor's office or outside of the hospital. It has to continue, and there has to be an economical tie to that, just the reality, for their interest in that happening. Not that they're not interested in the health of the patient. Most of these physicians have such a workload that's astounding. So they're trying to get to the next person to help. But there will become an economical thing, and it's coming soon, where it is in their best interest to work with Health and Human Services, work with the social service providers. There's episodic care reimbursement models right now, and some of the disparate programs, especially in New York, are organized around this, that there isn't an economic incentive, not just the Hippocratic incentive for physicians and care providers to look beyond the inside of the door of their facility and ensuring that that patient moves forward because they are outcome-based reimbursement models. So I think it's going to drive it, but I think economics is going to have to be the deciding factor.
Perfect. All right. Next question. Could you talk a little bit about the coordination among social service and health providers? How easy is it to work with them, and how do you get started?
Great question. So I'll talk just from personal experience. I will tell you the folks that I have worked with in the community organization that are the social services type providers, community providers everywhere from DHS to other organizations, are very willing to share information, excepting possibly some of the only thing I think more complicated information or data-wise getting the mental health or behavioral health data is information on children, right? And understandably so. So foster kid type information is kind of off the sheet right now. It's just complex. But other than that, they're very willing. They are very underfunded and low technology-wise, and I don't mean the people at all. I mean their ability to have the machines, right, and programs to be able to do the things that a lot of the other folks can do. It's just not there yet, but very willing to cooperate on the provider side and clinical side. And by the way, the state's the same way. The state, as long as you have a reason to get information, most states are very willing to get information in your hands about any of the clients that they pay for, Medicare, Medicaid, and federal, TRICARE. So they're very willing to share that information. From a provider standpoint, I think it does come down to what is the interest in it for them to do that, and I think that's going to evolve, and it's kind of the answer to the last question I gave. The way to have that happen is it's going to be an economic incentive that you've got to work with these agencies and make sure that when John Smith comes in, you want John Smith to come in for his checkup, right? You don't want him to come in because he's sick. And one way to know that is if you have an ability then to have this whole health neighborhood talking to each other through this community care share plan, so to speak. I don't see a physician getting outside of their EHR ever, and I wouldn't if I was one. Getting outside their EHR to go look into this other thing, right? I got another sign-on. I got to go look at this program, this client track thing. However, what I did start to see is the other providers and service providers are very happy to look at that. And when they do that, there is alerting them that can happen, right? That can happen into the EHR of that physician. so they don't have to open up the application. As long as you have your data infrastructure in your warehouse, organized the right way. There are ways, especially with fire technology, which is out right now, to deliver those information and those notices, the patient event notifications, into that EHR. It's there. It's happening right now. So that's one way to do it. So it can go into the doctor's workflow. Another way I've seen it happen is some of the larger practices that can afford somebody to do this is them actually having that interface through a care coordination tool, to where they have an office manager, a PA, or a physician's assistant, what have you, that actually looks at the roster for the day, looks at their people, and goes into that thing, and then brings that information to the physician. But I can tell you on the health and human services side, the social services type folks, they are very willing to engage in whatever manner possible with any technology to help them do their jobs. So I think it just really has to do, again, workflow eats technology for lunch, right? I mean, it comes down to the ability and the time that our true healthcare providers have to look at this information. So it's how do we get that into their hands quickly. I'll make one other point. I worked very closely with a chief medical information officer. Recently we were talking, and she made the comment that, it's just real-time delivery of information for me on my patients. And she said it's not real-time delivery, because if I have to go look for it, it's just too much. And so, I agree, and it made a good point with me. So in other words, if you set up protocols based on what a provider is looking for, or what a provider organization, right, the primary care practice is looking for, I want to know A, B, and C with my patients. I want to know my patients that have hit the ER and when they're at the ER. That's what I want to know. I want to know any of my patients that are being treated outside of our area. I want to know that. All those things can be done, by the way. Of course, if you own this infrastructure like I discussed and a patient gets treated somewhere else, well, you have that information if it goes through an HIE or there's claims information. And that provider can then be notified in what manner they want it, right, via text, email, phone call from a care coordinator. So I think making it simpler for the physician side of it on getting the information tailored to exactly what they want is the answer to that.
All right, so the last question we have time for, how are these different providers set up on a system? So is it pay individually? Is it a community-wide thing where they're all on the same system, right? There's a lot of complexity there. How does that work?
Another great question. I'll try and answer it without really knowing more information about what person is asking for it. Let me start this way. So providers live in their EHRs. They have to. That's their business technology, is their electronic health system. So they stay in their electronic health record system pretty much. What we were able to do out here, right, is to then connect those providers into an HIE. So it was great because then we were able to get information, like I just mentioned, to do a format that could be pushed out. If you're an EHR, if you're a doc in the ED, you don't have a lot of time to do a lot of things on a patient. But if you can quickly go into a place and say, oh, that's their primary care doc, oh, these are their allergies, then so that information is there. To answer the question, I don't know if Colorado Springs, Pikes Peak area is indicative of the rest of the United States, but I'm guessing it probably is. Our 42 providers, 38 are on different EHR systems, so they all have EHR systems. None of them really talk to each other. There's no way that you would ever want to try that lift of having them talk to each other. So the providers pay for their EHRs. How do you get this information to them? Again, it's going to come down to payment. So is it an ACO model? Is it a physicians group, right? Is it an IPA? Where you have a bunch of different docs that say it's in our best interest that we make our systems talk together. I don't know that the systems, having the different systems talk to each other, I think is financially unviable. I think, but incorporating the systems you want to work together into one environment, right, bringing all that information in and aggregating it through an integration engine into one environment, and then pushing it back out is really the answer to that. Who pays for it? Again, the adoption is going to come as health outcomes don't improve or payment models become much more financially incentivized to do so. In my experience, you either have a non-for-profit or a grant-funded organization that is going to get behind this, or you have a government organization, specifically at the county level usually, where you have county funds through some types of waivers. Maybe you have a Medicaid or Medi-Cal waiver, or Medicare waiver, where you're funded to do X, and you have to prove your outcomes, and so you get a certain amount of money to deploy whatever technology solutions you want. Again, if you own that domain, the providers are told, because they're county providers. The hospitals are county hospitals. The jails are county jails. So you're not in the business of asking them permission. You're just telling them you'll use this. And I think that's a much easier lift. But when you're dealing with the typical non-governmental side of it, it's very complex. I mean, who's going to pay for the front-end solution? And I don't have the answer to that.
All right. Well, thank you, Jim. That is all the time we have today, so we'd like to thank Jim for his presentation. Thank you to everyone who has joined us. A link to the webinar recording will be available on Monday, and we will be sending that out. Also a reminder, Jim mentioned that the second week of April he will be doing a webinar around predictive analytics, so we will get the details for that sent out soon. We will hope you will join us, and thank you and have a wonderful day.
Thank you.